All right, everyone. Good morning. I'm Bill Lavelle. I'm from upstate New York. I'm at SUNY Upstate. And today I was asked to talk about how do we measure quality, and I added a blurb, which is why it's in blue, value in a research and non-research practice. And so we're going to define exactly what value and quality is as much as you can exactly define them. We're going to talk about the relative roles of different stakeholders. We're going to talk about how cost is measured, and we'll give an example of exactly how this all fits in. And so to pay homage to our last speaker, Dr. Bervin does talk about this a fair amount. So we have to understand that there are a couple of things with regards to definitions that are important. So we learned when we were in school about the difference between accuracy and precision, right? So the difference between accuracy and precision is you can precisely throw a series of darts at a dartboard and have them all cluster together, but they could be nowhere near the target, as compared to when you accurately place the darts. You get more darts in the target, but they may not be as bundled together. So those are different definitions, and the same thing can be said about quality and value. Quality of care is measured by our adherence to standard processes, our measurements of how we are compliant and how we potentially improve patients. So quality of care can encompass things such as our ability to give antibiotics, our ability to have an electronic medical record, while value looks at quality and has that with respect to the patient's assessment and the cost that's incurred by that quality of care. If you look and try to relate these as an equation, some would argue that value equals the quality divided by the cost. So the value proposition in healthcare is the analysis of the potential benefits related to that care, and the measurements of the cost really depends upon who's paying and whose costs exactly that you look at, and we'll talk about that a little bit more in the next few slides. So a lot depends upon your perspective, right? So the funny slides that you see of the man stranded on an island and seeing a boat, and the boat that's floating freely in the ocean seeing an island, your perspective is really important, and we'll see that with regards to whose benefits are important and whose costs are important. So when we talk about value, what's a life worth? A lot of what quantifies our life is our ability to live our life with a degree of what would be a normal state of health for that individual. So if you take this individual, he's probably not the most healthy guy around, but he's healthy enough. He's 44 years old and hopes to live another 40 years. Let's say he was diagnosed with a terminal illness, and that terminal illness has a potential cure, and that cure costs $1 million. Does that sound like a lot of money? Well, if you look at that over the lifespan of 40 years, that's about $25,000 per year of normal quality of life gained if you're willing to pay for that $1 million intervention. And that's really some of the things that we argue with regards to quality of care and the cost of the things that we do. Talked a bit, and may not have used the word a utility score, but we are measured by what is a degree of perfect health, which can be defined as a value of 1, and death, which is defined as 0. And believe it or not, there are things in life that are worse than death, and you can even have a negative score. And so we've already heard a little bit about the standard gamble model, whereupon an intervention in and of itself has risks that may affect your ability to have a normal utility score or have a utility score that's closing in or approximating a value of 1. And we heard already a little bit about some of the very dangerous things that we do with regards to spine surgery. And deformity surgery gets a fair amount of attention on this due to the relative risks of the procedures and their potential complications. And as we heard, already that depending upon whose data that you look at, and there are a number of them out there, your complication rate is substantial, with some of those complications having very meaningful impacts upon a patient's utility score or overall quality of life. So quality measures are tools that measure or quantify our healthcare process. They try to assess the outcomes of our patients and their patients' experiences. So again, even our quality measures depend upon who you are. So if you're a hospital system, one of your quality measures may be how soon we get a patient out of the hospital. And in previous years, as Dr. Bervin had cited, he had given an example of a patient who had a substantial sagittal plane deformity, who had a very modest procedure that involved, I believe it was a one-level fusion, that from a cost-benefit analysis looked good for the hospital, patient left early, but from the patient's standpoint, they didn't really gain much in terms of their quality of life outcome improvements. So there are certainly process-based measures, such as how long your Foley is in, process-based measures from us as a stakeholder, surgeons, how well we improve their measurements in terms of their deformity or their cervical alignment or their non-union rate, and they may not entirely relate to what patients would perceive as improvements of quality. And that's why there was the advent of such items as patient-reported quality of life outcome scores, and there are numerous of them. So this is just an example of patient-reported outcomes. It's a busy slide, but highlights that even those fall into two broad categories. Ones that would try to let us relate different disease processes, such as general healthcare quality of life outcomes, like SF-36s. That lets us compare things like cervical fusions to treatments for people with oncologic processes. There's also disease-specific scores, such as the SRS scores, the SRS-22, SRS-24, and the JOA score, which specifically looks at the impact of myelopathy. So these scores are one way for us to try to quantify the quality of our improvements of care for patients. So again, it really is an element of your stakeholders. So we can see quality measures that are important to one stakeholder that are potentially not important to another stakeholder. Length of stay. Length of stay in terms of shared elements of cost is very important to stakeholders who value that component of it as compared to quality measures such as patient-reported outcome improvements or patients' degrees of complications. They may not necessarily be the same quality measures, but there may be interrelation between them. And also, again, there is some degree of things being misleading. We can discuss from a hospital standpoint about our improvement of quality. Improvement of quality meaning that we've removed your catheter sooner or that we sent you home sooner, but that may not have a direct impact on patient healthcare quality of life outcome scores. So how do we quantify quality? And one of the most talked about measures is what's called a qual score, which is a score that is determined algorithmically by the number of years where the patient's status in life that is close to a status of 1, which is as normal as possible, is some product over the number of years of life that are measured. So if you see in this particular example, if you have 5 years where an individual is in perfect health, 3 years where they've had limited mobility and they've been assigned a utility score of 0.85, and 2 years where they're doing not quite as well with a utility value of 70, if you look at the sum product of those scores, you can look at the qual value over 10 years as 8.95. And again, how are you determining that utility score is an element of who you are as a stakeholder and that component of a debate? If you look at it, it's a topic that has had more and more discussions. This is a stolen slide from another source from the AAOS that talks about how there is many more articles that talk about qual scores. And again, it's more than just surgeons that are involved in this. There are patients whose opinions are particularly important, but there's also societal questions. And societal questions fall to more than just insurance carriers. They fall to you. Some of the things that we do, as you see, are very big and burdensome, and we do them altruistically to try to help people as much as we can. But they come at a great degree of cost. If you look at, anecdotally, components of analysis of how much money is spent on patients in insurance pools, the argument is made is that 20% of the people use 80% of the resources. And how do we feel about that as a society? The other thing I would bring to you as preponderantly a room full of surgeons is in terms of cost, what is your time worth? So there's been moves today, particularly one of the hot topics is pre-authorizations for the surgeries that you do. And while there may be improvement of quality according to an insurance carrier, this one carrier that is cited in this example argues that between 2006 and today, the rate at which surgery has happened in the spine has drastically decreased from 4.1 per thousand in their patient population to 2.1 thousand in their patient population. And the question is that a good move with regards to insurance cost savings, or is it a bad move in which patients are denied care? And I'm sure you surgeons in the room can also attest to how much of your time is occupied by dealing with pre-authorization issues. Perhaps your time bears a value in this equation as well. Another term that gets defined is something called an Eicher score, which is the comparison of the cost of one treatment compared to the quality of that treatment. And that's compared amongst two different treatment interventions. So you look at the cost of treatment 1 minus the cost of treatment 2 over the quality of treatment 1 minus the quality of treatment 2 as we determine the incremental value and the effectiveness of that particular intervention. So what do you look at with regards to this term? You look at specifically, the question is let's say we go from, let's think of an example, HA peak cages, which may be more expensive, to regular peak cages. What's the Eicher score and what's the relative value of that? If you can avoid pseudoarthrosis and substantially save secondary surgeries over the time frame which you analyze the patient, then maybe there's a substantial Eicher score that's worth arguing for that particular change in terms of intervention. The number that gets assigned in terms of what is a meaningful amount of money to be paid for quality adjusted life years is debated. Some would argue it's 100,000, some would argue it's 50,000. I think most would argue is if you can get the best bang for the buck that you can, the better off that you are. In this particular multi-axis model, you would see that anything that reduces costs and improves utility is desirable. Anything that increases costs and makes our utility worse is certainly undesirable. But life is not a perfect trade-off, and what we need to do is try to find the best trade-offs that give us the best bang for our buck. Again, whose values are important? I mean, I certainly every day in my office see patients that come with different sets of goals and values. You see the patient who's a workers' compensation patient who hurt his back, who's desperately seeking a spine fusion, even though I tell him that the chances of a spine fusion helping him from a back pain standpoint is at best 50-50. You also see someone like the lady on the right who is elderly, osteoporotic, has a substantial amount of standing balance issues and disability, and has heard that we can try to help her with a spine deformity surgery. All of these may have personal values, but we as surgeons have to look at trying to assess what we can do to try to help them and trying to assess the cost and the implications for us as a society and for that patient as an individual. So let's give an example of where that fits in from a relative standpoint. This is an example of an ACDF model that was reported in Spine in 2014. So ACDF without a plate and ACDF with a plate. ACDF with a plate procedure has a higher cost. The application of a plate costs about $1,500 at this particular center at the time that the paper was analyzed. So what would a payer say? So a payer would argue that if you're paying an additional $1,500 and the patient's radiculopathy goes away, well, then that's probably a better choice of a procedure to have because it costs less. So your quality is the same, but your value is better without the plate. The corollary argument is let's say the patient who has the plate doesn't have to wear a collar and they go back to work 3 weeks sooner. And so while a patient's payer may cost them more money, how do we look at this from the patient standpoint and a societal standpoint? So as a society, if this person is a worker who brings us value, perhaps he drives a bus, perhaps he's a government planner, and his return to work brings us societal value, or brings him individual value, he's able to go back to work and earn money sooner, perhaps that value equation changes. So what's your time worth? That's always a question, right? What's your time worth as a surgeon? What's the value of your time as a patient? And those really are important discussion points. There's other examples of a similar model that does a comparison such as this. This is an example of what's it worth for you to have a disc arthroplasty versus having a fusion. And this is an article that looks specifically at the cost of complications, looked at the costs of and rate of adjacent segment arthritis. And in this modeling, it made an argument that depending upon your patient's age, that the time frame at which you would have an ACDF versus the time frame as which you would have a disc arthroplasty has a meaningful difference in the amount of money that is different between those two procedures in terms of long-term cost. So in conclusion, what have we learned? Well, we talked a bit about things already. We learned that value and quality are related. So value and quality are related in the fact that quality divided by the cost of care would lead to what the definition of value is. But a lot of that depends upon whose perspective you're looking at this from. If you're looking at this from the insurance carrier's standpoint, if you're looking at this from a doctor's standpoint, if you're looking at this from a patient standpoint, if you're looking at this from a society standpoint, they all are very different perspectives that in some areas meet and in other areas certainly do not. Again, cost is relative to the stakeholder, and certainly, as we've heard about from the last talk, is that we need a lot more data to try to help us to try to understand this issue better. It is a hot topic. And in our next talks, we will hear a bit about different ways that we can try to organize and change elements with regards to quality of care. So, cool.